Hi everyone, my name is Clara. I'm the ECC Registrar and Clinical Supervisor at Peninsula Vet Emergency and Referral Hospital. Welcome back to another Vet Wrap, the podcast episode. This is a little snippet, bonus, little content. It's basically troubleshooting with an expert. And the expert I have today is the amazing Jess, who is our nurse team leader in our referral practice and is just anything needing to do with anesthesia that I am boggled by, it's Jess. Jess is my go-to person. So I wanted to have a chat because we currently have a patient in hospital. And this particular patient is on a mechanical ventilator and its end-tidal CO2 is not behaving. And this is something that I recognize with myself a lot. Whenever I have an animal under anesthetic, if I am doing the anesthetic, I struggle with troubleshooting. So a nurse has done an anesthetic with a dog. It's a septic abdomen. Dog's under ISO. It's had medetomidine and methadone as its pre-med. It's on a fentanyl CRI. The nurse has had to duck out from the anesthetic, so I've been asked to go in. And I go in and everything's perfect, everything's fine. And I push my hand on the dog's head and all of a sudden the Irish bad luck has come through and my end tidal has shot up from, 30 right up to 60.
Wow.
I'm assuming it is just the hand,
Yep.
But I'm immediately in panic station. And I will actually say this does happen to me because I do find sometimes with end tidal, I struggle with where to start.
Yep.
So what would be like your first go-to thing that you're looking at doing?
So I guess the biggest thing to look at to start with is go back to the basics. Mm-hmm. So we need to think about our anaesthesia depth and seeing whether patient has suddenly gone too deep, whether that's from the drugs that we're currently giving or it could be the fact that we're not providing, appropriate analgesia.
Okay,
And just a couple of things to just, before we move into the whole other category of, looking at ventilation and how well things are going, we do need to go back and think about, could this be because my patient is not adequately at the appropriate depth that we need it to be?
Yeah.
Are they hypoventilating, for example? So from this perspective, these are the things that we start to look at as our step one. Mm-hmm. And let's say we have gone and done all of those things. The depth is adequate. We've checked our palpebral reflex, our jaw tone, our eye position and everything. We've assessed that our analgesia is appropriate as well. Whether the fact that could also be too high. Are we over-analgesing our patients is one of the biggest things that we have probably overseen because we're so worried about all the other things like are we adequately ventilating effectively and everything, but we also forget about how high is our analgesia.
It's very true. And I think especially in ECC, we're very bad culprits for putting them on very high doses of fentanyl and ketamine. Which again, they need, but potentially during that surgery period, looking at a different option or like titrating it. Okay.
Yeah. And then from there, generally, this all will take about like 30 seconds for you to do. So this whole process might seem like it's going to take a long time, but this is about a 30-second check for us.
Yeah.
So the next step we would look at is what is our ventilator doing?
Okay.
How is our patient breathing? What is our respiratory rate? What is our tidal volume? And looking at our amount of pressure that we're providing the patient as well. So then we would look at effectively what's our tidal volume doing? Is it too high? Is it too low? In this situation with our end tidal CO2 being too high, this means that we're not providing enough pressure to the patient.
Right,
so should we be giving it more? Our normal tidal volume that we're looking at is between 10 to 15 mils per kilo for our patients. And then from there, we are going, okay, let's say this is a 30-kilo dog.
Yeah.
Okay. All right.
It's a 30-kilo Jack Russell.
30-kilo Jack Russell. Excellent. I'm concerned about its weight. Lord help us. And from there, what we're doing is we are going, okay, so that's about 300 mils. And then we go, okay, so the patient is only providing 280 or 250 mils. So here we need to improve, effectively remove that CO2 from the body because we've got all this excess CO2 occurring. Why is that occurring? We have to think about that. And then from there, we're going, okay, let's try and increase the pressure. So will this help our patient? People always tend to stick with 10 mils and don't actually go to know that we need to be at 15.
Yeah, okay.
So we always actually think, oh my God, they're at 300 mils.
That's their max.
That's their max. We can't go anymore.
Yeah.
And at the end of that, we're going, no, we've got a lot of room to move here.
Yeah, amazing. Okay, so I have gone ahead and I've adjusted my tidal volume. Is there anything that I need to kind of be looking out for with that? Like, can that cause issues in itself?
Yeah, so when we're looking at our tidal volume, we also look at our peak pressure. And that's called PP on your ventilator. And what we're looking at is we don't want this to exceed 18 centimetres of H2O. And then from that, we're observing when we're adjusting our tidal volume up, down, many ways you want to do it. We are looking at how much can we push this patient to, let's say, 18 centimetres of H2O. Okay, is that enough? Then we're going to go look at, okay, let's look at our respiratory rate, see what we can do with that.
Okay. So, yeah, we can't just set and forget and be like, I'm sure that's fine. We have to make sure that we know that there could be a pressure thing that we have to look out for as well.
Exactly.
Okay.
Yeah.
So then, because I know, and I guess now that you're saying that, what I would usually do, I see a high end tidal, and I'm like, oh, respirate, adjust my respirate straight away. But clearly that's actually not always the best thing to do, because if I am just adjusting respirate and not doing, first of all, the first step, but actually not looking at my tidal volume, I mean, I would probably just see maybe a slight improvement, but it probably wouldn't last.
Correct.
Yeah, okay. Yeah.
And then after that, usually what I go to is then the respiratory rate. And then I'll look at, okay, so do we need to improve this respiration? What are we looking at? What was the normal for the dog before it was anaesthetised? Because we always forget, let's say we had a patient that had come in and it was like 20 breaths per minute, but that was its actual resting respiratory rate. We are going automatically to 12 to, let's say, 18 breaths per minute. And from here we're going, oh, actually, this dog's normal when the patient is awake is 20. So we actually should be at, let's say, 20 breaths per minute.
Yeah.
But usually the case is that their respiratory rate resting is not going to be 20.
Yeah. Well, but
anxiety in hospital.
Exactly. And I think even like in the GP setting, going and looking at, well, what was it the last few visits they came in, yes, maybe they weren't resting, but maybe it wasn't as crazy. That's really, I have never actually thought about that.
It's one of the things that I do bring to my nurses a lot is just we always go back to, especially like going off topic a little bit here, but we look at heart rates and we go, what was the patient's normal heart rate before we were anaesthetised? Because we have to remember what is normal for this dog. Every patient does not have to go off the vital signs that we are told in school. Yeah,
everyone's an individual, 100%, 100%. So then if you're in a scenario where, if I'm in my scenario with my septic patient and I don't have a mechanical ventilator, how am I, which I think is obviously a lot of the cases for a lot of our GPs as well, how can I achieve my change in tidal volume or pressure if I don't have the ventilator that can do that for me?
Well, first of all, I hope that never happens to me. Because I love my mechanical ventilator. But at the end of the day, generally what we can get is these things called a manometer. So they're pressure manometers that you can get from Sound Veterinary, and they are disposable after, like, let's say 30 uses or something. Okay. So you can also get that, and you can use that to be able to see how much pressure you should be giving a patient. Because one of the things when we're doing our intermittent positive pressure ventilation is we may not necessarily be giving enough of pressure in that breath.
Yes, we're just kind of looking at a bag and squeezing.
And we're just giving a squeeze, but when we don't have that manometer with us, how do you know that you're not overdoing it, underdoing it? So we're looking at the patient's lungs like we should be, but at the same time, how do you know how much is too much, how much is not enough? Yeah,
and it's probably people, I mean, in the industry, we're all so cautious anyway. We're probably all underdoing it without a manometer because you don't want to overdo it. So you're probably even being more careful and more gentle.
Exactly.
Oh, okay. And so say we've done all of those things, like what is an end title that scares you?
I start getting a little bit nervous from 60.
Okay.
Because like sitting at the 55, I'm like, okay, so there's things that I can do here. And then sometimes there's parts of anesthesia where you just can't understand why you cannot get this patient's pressure down or their end tidal CO2 down. And we have to look at all of the factors like what's our patient's weight, how much fat is around that, their lungs and everything.
And
like
the diaphragm, everything's
the
pushing
diaphragm,
up.
like what are we working with here? Like do we need to elevate the table? Like taking consideration all the things like how much pressure we got of all the organs being compressed up. Could we elevate tables? Could we
even tilting it?
Exactly. So they're all the things that we have to remember to go back to and think, what is my physical component of this patient that we're looking at? We always have to remember to go back to not watching just machines and looking at the overall picture. Always patients first.
Actually putting your hands on them and actually looking at them. Okay. Well, I think after that I'll be able to help my septic abdomen patient. Thank you very much for that. Thanks for the little troubleshooting tip, and join us next time for another one. Thanks, guys.
Thanks.
Okay, that's a vet wrap. Thank you for joining. Feel free to comment or get in touch via email. The email address is education@penvetreferral.com.au. You can find this podcast everywhere you listen to podcasts. We're on YouTube, we're on our website, and please don't forget that we have an education hub on our website. It's free for vets and nurses. It is an amazing resource. We're constantly updating it. And yeah, thanks for joining.